also make up North Somerset too. So North Somerset has the third largest inequality gap in the country, so we do have some real areas of deprivation. And we are the most deprived area in the 1% in England as well. So we really do have, here in Western, in Central Western and the Southern Ward, we do really have some pockets there of population that are in need. In terms of the next 10 years, we really anticipate that the increase in our population is going to be in the 75 to 84 year age group. So again, like other areas, a real ageing population. And we have Peer Health Group, who are our GP practice, and they're our main PCN, so we have one PCN in this area with 8 GP practices. We also, which makes us stand out as an area, have 1,700 care home beds across 65 care homes, so that's a real significant part of our demographic. So as a locality partnership, our philosophy is really built on the needs of our population, as you can tell from my last slide. So we're working together with partners and with people with lived experience to develop a clear vision, which is very transformational in this area. We're really action focused as a locality partnership, and we like to be brave and we like to test and learn, and that will come through on some of the pieces of work that we've done. We're really keen to get things started. We don't like to get we really want to get things sorted out, and also we're really collaborative as a partnership in creating that change. We've really learnt together over the last 18 months, and we're looking forward to the more challenges that we've got coming, which I'm sure there will be many.
Yeah, there will be. And I'll just add to what Ros has said. I think the reason that I'm here today is it just shows what a collaboration there is between health and the voluntary sector in North Somerset, and particularly in Western Whirland villages. It really is a true collaboration, so I'm more than happy to be here today.
Thanks, Mandy. The next slide talks about the top 5 impactful conditions in Western Whirland villages, and as you can see on there, mental health is a real dominant factor, particularly with the under 50s age group, and we'll talk about how we've managed to address that later on. This includes high levels of alcohol and substance misuse as well, which is particular to our area. We also have a lot of people with painful conditions, and that's throughout our life course. So whilst it's prevalent in older people, as you would expect, it's also prevalent in younger people. And we have dementia, diabetes, COPD and atrial fibrillation are all common in our area too. So these are having real impacts on our population and their ability to lead good and fulfilling lives. So our story so far is that since September 21, when we really came together and started to do a lot of work as a locality partnership, we've designed and delivered an integrated mental health hub in Western. We've expanded our care home hub, which again we'll talk about in a minute. And we're co-designing our 5-year plan and a model of care for ageing well. So they're the 3 kind of areas that I want to sort of delve into a little bit more today. We're working really closely with the voluntary sector, as Mandy has just said, and also as part of that work, we've developed a virtual hub which is linking people to their communities and really making sure that we address some of the needs, and one of those needs is around a befriending alliance, which we've managed to develop in the area. And all of this is underpinned in ensuring that we have great digital solutions to help us to do our work, and also making sure that we can focus on the needs of our population to design all of those areas. So I wanted to focus in on community mental health. So in response to the community mental health framework, we designed an integrated mental health team, which is based at the Coast Centre here in Western, and that's supporting people who are falling through the gaps of primary and secondary care. We wanted to make sure that those people weren't left and that they had the right support at the right place at the right time. So we set up, in the first instance, an opportunity for us to all work together as partners virtually to bring together our knowledge and skills and experience to really start to think about how we could work on a shared caseload. And we started that off in February 22. And that's evolved since that period of time, and we've done more work to bringing together a physical base at the Coast Centre, and that's been up and running since October. So the next slide will actually show you a little bit about who's in that hub and the roles and responsibilities of the people there. When people get support from the hub, they have something called a support conversation, and that's very much about talking to people about what matters to them. What are the things that are going to change in their life, and what can we help them with? So we've had some early indications from that work, which has meant that we are really sort of starting to shift people's lives and improving their outcomes. So we've got some very early indications that that's actually successful, which we're very proud of. So at the moment, that hub is working with people that are falling through the gaps, that are not meeting that criteria for secondary care. But we're also then starting to get direct referrals from our GPs. So over the next month, we're onboarding all of those GP practices in West and Welland villages, and they'll be able to make direct referrals for people. We've also had some interest from NHS England, who've come down and helped us with our personalised care training, which has been really, really beneficial. And it's meant that the team down at the hub are really, really clear about personalised outcomes for people, which has been fantastic. The future for the hub, we're looking at them taking on referrals from 111 service in the future, probably by about September. And we're also going to be carrying out a period of evaluation to see how the service is fared in terms of its effectiveness. So the other area I wanted to talk about is our care home hub. And as I mentioned, we've got 1,700 care home beds across the area in 65 care homes. And due to this level of demand, there was an inconsistent and inequitable medical care to all of those care homes. So the care home hub was set up very quickly and has been relieving the pressure on 999 calls from care homes ever since. So it's doing a fantastic job. It's preventing people being taken to hospital and ambulance conveyances, and it's also obviously through that avoiding hospital admissions. I think the key thing of what's made that work is that it's been building trusted relationships. There's a strong primary care network in the area, so that's been really helpful in terms of moving it forward. The collaborative partnership approach within that work, and really starting to change the culture rather than just process. So that's been a real success factor in making that work. And I think so far we've managed to get an expansion of around 50% of all of our care homes. So we're providing that service for 50%. What we really need to do is get up to 100%. So we're going to need continued support to make that work. So that work is by no means finished, but is going great guns. On the next slide, we've got a picture of a house, and that's really sort of how we're working towards our model of care for ageing well. You can see there that we're really trying to join up all of the services in our area to really make sure that it improves outcomes for people. So we know we've got the parts, and we know that the parts are working well. What we really need to do is join that up. So you'll see that we, at the top there, we're really looking to develop a later life coordination hub in the same way that we really have around community mental health. But how do we join all those things up to ensure that we support people? And really importantly, obviously making sure that we support people to live their place of choice in their communities through the voluntary sector, through things that keep them healthy and well. But also, when it's appropriate for them to go into hospital, that we've got really good links with Western and the Change programme there at Western General. And again, just the next slide is around how we're linking everything together. And I think we very much believe in putting the person in the centre and then really starting to see about how those services and that kind of diagram there just, I think, reflects some of the complexities of how we're going to do that. But we're very keen to do a similar piece of work at community mental health to join those things up. And the last slide is really just to reflect our partnership and also the fact that collaboration between us all will continue to help our local Western Welland Villages population to live healthier and happier lives.
Thanks,
you.
Ros. Thanks, Mandy. Any questions from board members? Perhaps I can start us off and just say that these are superb examples of how you come together collaboratively towards one public service for our citizens. I'm interested, particularly on the Community Mental Health Hub, is that something you just designed for yourselves or something you picked up from somewhere else? And then on that point about success and outcomes, it's sometimes difficult to do that by way of figures.
Yeah.
Surely you've got some case study or narrative, which I think would be really helpful to share across all our partnerships.
Yeah, absolutely. So in terms of our mental health hub, we obviously had the community mental health framework as a guide, so that was really important that we followed that. There was other good practice. Somerset, for example, were a pilot site, so we looked at those. But very much actually what we did is we worked across the partnership, and we have a meeting that happens every Thursday morning. Everyone attends it. We developed the model ourselves. We understood what it was that we needed using our population health data. And we got everybody who knew, including people with lived experience, what was needed. And we built the model from scratch ourselves based on what was needed for our population. So used a bit of everything really, I think, in terms of how we developed that. And we took an approach where a few of us were trusted to go and do a piece of work and then bring back to the group, and that approach really worked to get us moving in terms of actions and being able to work that forward. In terms of outcomes, what we've done is our support conversation that I mentioned is actually has got dialogue plus scores attached to it. So we can measure someone's outcome when they first become involved with us and then see whether their outcomes have changed afterwards. And that's a really good measure because that's from the person saying how they feel and what their experiences are at the beginning and whether that's changed over a 3-month period. So that's the kind of measures that we're using. So we're going back to people in 3 months' time and saying, how do you feel and how has your situation improved?
Brilliant. Just one more question from me then. Before I open it up, I'm overindulgent a bit. But just the support from the board, so by way of resourcing and finances,
Yeah.
do you feel that dialogue into Dave is working?
It isn't. Dave and I talk all the time. So it is. I suppose in terms of, we've done this on a very small budget. So if you look at the community mental health, it was a very small budget. What we did was we harnessed all of the other organisations, some of who sat in this room, and it was the commitment from those organisations that gave the time. We didn't buy slots of social work or anything else, to help us develop this. It was the goodwill of the partnership that really made that work through. So I think that's great. Having said that, development costs money, doesn't it? And I think probably you asked about what we could ask of the ICB, and I think the thing I would hope that you would take away from this is there's some really good examples if localities are able to have the resources devolved down, and you can achieve it in a much more effective way than you can maybe by sitting in, doing lots of different slide decks or theorising or strategising. And I think that from certainly my point of view, having led this partnership, has been the success. So I think it would be around everybody in this room thinking, can this be delivered at locality level? If not, why not? Why are we doing it differently? So I think that would be my plea.
And I think from the voluntary sector, it's a sustainability element of it. And I know we've talked to Shane about this before, but I think we're willing and we want to be involved, but we haven't always got the resource to go to all the meetings every Thursday morning.
Absolutely.
And that we have to fund ourselves.
Yes.
And so we see the value of it and we're prepared to put that resource in, but it's not, it's finite. We can't keep doing it. I have to pay for someone to be there, and I can't keep doing it. So I think in order to make something sustainable, there has to be resource. It always boils down to that sort of thing. And I think from our perspective, we really value it. The Befriending Alliance has come out of this work. That's very strong. They had a meeting yesterday, bringing all of the providers of befriending services together under one umbrella. for training, for promoting, getting more volunteers involved. I mean, it's all really valuable work, but there does need to be resource,
Yeah.
and it does need to be sustainable resource. So living 12 months at a time is really difficult because you build up a relationship and then it goes and you have to start again. And we're losing good people in the voluntary sector.
And this is an age-old one, isn't it? You know,
It
around
is,
the, around
it is.
The,
I'm not
having to
telling
make
anything
bids all
down
the time. We have made some money available this year for voluntary sector engagement,
Yeah.
which Colin Bradbury should be speaking to you about, or Dave will be, but yeah, they're points well made. So let me bring in some of the other board members. So Steve, and then John.
Thank you for sharing this. It's a really good piece of work. One of the things that obviously we can do through these local schemes is to learn. So the question I'm going to ask you is, if a neighbour came along and knocked on the door and said, how did you do that? Do you have a blueprint? And
Yes.
you say, here, this is what we did, this is how you do it.
Yes.
Because for us, the real jewel in the crown is if we can scale at pace
Yep.
where we're seeing impact. So there's two bits. What are the impacts? Because that might answer the question about how do you get it to be sustainable, because you'll be saving money through this system.
Yes.
So how do we close that loop?
Yeah.
And then the second piece is, if there is impact, what's your blueprint for somebody else knocking on the door?
Yes, absolutely. So we can pull a few things out to measure our impact at the moment. So as I mentioned, the Dialogue Plus scores, so we can see we're showing an impact. We can see that people aren't being bounced back to their GP, so we can see an impact there. We can see we're starting to see an impact across social care because we've got someone from social care in the hub. So we're seeing that we're just about to do some work around measuring that. So we can pick up a few bits, bearing in mind it's early days, so we've picked up a few bits and pieces around our effectiveness between now and then, but we've got someone from Bristol University coming down to do an evaluation piece, and that will be completed in October. So we're really looking forward to working with them and really pulling out a lot more information from that. I think probably in terms of can it be scaled and do we have the blueprint? Yes, we've kept absolutely everything. There's a pack that can be kind of handed over in terms of this is how you do it, these are key documents, all of those sorts of things to help people who want to implement that model in the future. We're also sharing with other localities, so we regularly share progress, and we've been to speak to other locality boards about their models going forward, particularly around community mental health. So we're doing that shared learning and that join up.
Thank you.
And that happens, those meetings happen in the voluntary sector as well. So
Yeah.
I meet regularly with my other locality lead partners, and we discuss things and share good practice that way as well. So it's happening sort of from both ends, really.
Brilliant. John and then Sue.
Thanks, Jeff. The question has actually been answered. I was going to ask about sharing good practice. So just an observation. It's just been really, really interesting and powerful to see how each locality has gone about its business and done the prioritising in the best interests of the population. So it's just kind of a reflection on seeing all of the partnerships over the past few months, and just been really, really great to see this. So thank you and well done.
Thanks, John. Sue? And then Dominic. You need to speak up a bit,
Yeah,
Sue, I
sorry.
think.
Yes. Yes. It absolutely is, and I think the type of people that we're supporting are those people that are falling through the gaps. So we know that people are supported in other ways via the crisis team if they needed it, or via 111, and there is support there around mental health and 111. So we knew that if anyone was in crisis, they've already got that infrastructure there to support them. So, but absolutely, we're going to look at all aspects of the service, and particularly the outcomes for people, but also how organisations are benefiting and how it's benefiting the whole system as part of our evaluation. Yeah.
Okay, thanks. Dominic?
I'll start by saying when the whole of this Parsons system, when the whole accounting model is deployed, I will start because it's a new type approach rather than design approach, and I'll set as to whether that will actually work. What I would commend this team in particular, they've set the standard. This is actually what we can do is an overall for me, the question, however, is, whilst it's clear it sets the standard, is it a blueprint? Can we extrapolate from it and work horizontally across the other localities to all of this standard? I don't know the answer to that question, but it's a really important question.
Yeah. I think my observations on that would be that there's a core that runs through our model that can absolutely be upscaled, I think, but we also need to bear in mind, as we've spent a long time looking at the needs of our population here in Weston, that that's happening in the other 5. So I think it's very much around there will be local things that we need to take into consideration, but in terms of setting up the thing, if you like, then there are lots of things that there's a core to it that could run through.
Okay, thanks. Do you want to come on that point, Dave?
Yes, and just building on Dominic's points, I think what has been amazing about the Western locality team in particular is they've developed a model and then they've got it done. And you know, delivery and seeing service change in our locality has been absolutely brilliant. And as you said, Dominic, the many flowers bloom model at the start, but the localities and the community mental health team have recognised the brilliance of what's been established here, and that core model is now, as you know, is going to be the kind of core basis for all of the integrated teams with that local tailor, which I think we are already sharing and learning that through the wider model. So just to echo my thanks.
And can I also say it spreads out into other areas as well, because those relationships are so strong. It's meant that when we've looked at other areas like ageing well, that those relationships are already formed, so you don't have to do it all over again. So those partnerships are so strong that we can actually take it out and look at it in other areas and share that beyond the mental health hub. So it's been very valuable in lots of ways. It would be really difficult to measure because it's almost like a network.
Okay. Can I bring in Shane and Ellen, and then I'm going to draw us to a close if I can.
Yeah, thank you. First of all, just say thank you. Not just thank you for the presentation, but thank you for what you're doing. I suppose it draws out a really interesting point, which is you have a culture and a set of relationships that have been built, which have allowed you to build a model and then deliver. If you lift and shift a model from position A to position B without having done that work of building the culture and the relationships, I fear that model of scale and spread may not be as successful. So I think we still have to do the work of building that culture in all of the localities and then take the best practice model of delivery and place it into that cultural change. Because, I mean, this is the most respect possible. The model is what's made this successful. What's made this successful is the people and the relationships you have in Weston.
Absolutely.
The model is nearly a byproduct of that. And the lift and shift that would just worry me that you go, well, it's worked in Weston, let's put it in the City East. And you go, well, have we built the culture and the relationships in the City East? So it's brilliant. We've got to learn from the process, not just the model.
Absolutely, absolutely agree.
Points
I
are
would
made.
agree.
I think Dave, to be making sure that we are sharing good practice and learning is valuable. Ellen?
Yeah, I think most has been said actually. I'd just like to congratulate you on fantastic work. The Care Hub just sounds, wonderful. You talked earlier on about prevention, sort of stopping people going in the first place into an acute setting, and this sort of answers an awful lot of those challenges. So my question was on Blueprint, which was raised by Steve, and I think answered by Shane and Dave. My question, therefore, would be collaboration. You talk about you've got obviously good levels of collaboration. How far and wide does that go? Are you sort of discussing with Serona partners, the acutes, and are you sort of reaching that far?
Yeah, absolutely. So all of the partners across the areas, that includes Serona, for example, are part of our partnership board and our senior leadership team. So very involved at a senior level around making sure that, you know, all of this is aligning to what we need to do for the needs of our population. So yes, absolutely, yeah, every partner is involved in that.
Okay, thanks, Rosamund. Really appreciate you giving up your time today. I mean, I think you can see from the conversation and the comments that people are very impressed with, you know, a lot of the brilliant work that you're doing. So keep it up and congratulations. And you know, anything you need from us, you know, needs to come in through Dave Jarrett to make sure that we are consistent in what we're providing to our locality partnerships. So you're welcome to stay for the rest of the meeting if you like.
We'll go. Okay, thank you.
That was too quick.
I know, sorry.
Thanks very much, both of you.
Thank you.
Okay, ladies and gents, if I can move us on to the minutes of the meeting on the 2nd of March. Is there any, as the lights go out, is there any issues, comments people like to make on the minutes of that meeting? No? Okay, thanks. So we've got 4 or 5 outstanding actions. The first one was for Joe Medhurst around decisions regarding discharge to assess. Joe's not with us, but I think she's going to update at the next board, Shane.
Yeah.
And then there's 2 on there for Lisa and Rosie around consideration to be given around the EPQ committee in terms of the MOU. So I don't know whether you've got an update on those, Rosie.
We had the clinical care leadership piece of work last week. We used the bow tie model that we've done in Bull before to work through some life problems as per the actions. What I now need to do is, and they found it really useful, by the way. I thought it was going to be quite a hard thing to carry with a bunch of health and care professionals, but when they got into it, it was a really good conversation. So it's helped us think a lot about risk and risk escalation. And then I need to meet up with Lisa and tie that into our quality escalation framework for the ICB guidance, but also the enforcement guidance piece. So we've done the first stage, Chair, but we haven't done the second.
Okay, thanks, Rosie. I think you can probably take it off as an action.
So, because we'll just take it now through into building it into the system governance now.
Brilliant. Okay, thanks very much. And the next one was around, Shane was around the single reporting. I know we've discussed that. I don't know whether you want to give an update to the board.
So we discussed the last board meeting. We are absolutely committed to creating a single dashboard which allows us to look across all of the performance indicators in our committee. So we will start working on that. I know we were trying to do a bit in between board meetings, didn't quite work, we wanted to work. We are on a path now and we'll be modelling what a dashboard would look like, which would try to bring in very simple terms the relationship between activity, quality, cost, workforce, etc.
Okay, thanks, Shane. And I know that's one that the Neds have pushed on, are quite keen to see, so that would be quite helpful if we can get an update on that.
Yep.
Then the final 2, Dominic, there was one on there about opportunities for delegated commissioning. So I don't know whether you've had a chance. Yeah. Okay, thanks, Dominic. Perhaps we can keep that one live then, Sarah, until next time we meet. And then the final one was around services for asylum seekers, Dave.
So we actually spoke about this at our executive team yesterday. We're bringing together a strategic oversight group to consider support to asylum seekers across BNSSG. I mean, it is a huge issue for our system, Chair, and I offer the opportunity to come and speak formally at the next board with the work, with the terms of reference to that group and the work that oversight group is going to get.
Okay, thanks, Dave. I think that would be a helpful one as an update for the board, a presentation on it. That would be good. Thanks. Okay, any other questions or comments on the action from the last meeting? No? Okay, thanks very much. In that case, I'll move us on to the next agenda item, which is the CEO's report. Shane.
Thank you, Chair. As you know, colleagues, I tend not to do a report which is backward-looking and saying all the things we've done, but rather what are the 3 big things looking forward. In today's report, I've raised the issue of our current ICB organisational structures, then looking at the cost reduction challenge that we have, and then finally a little bit of industrial action. I'm not going to go into huge detail. The report is there for the board chair, so I'm not going to go through page by page. What I would just summarise the first area of organisational structures. The board will be aware we're going through a 4-phase approach to changing the structures within the ICB, which is resulting in a new way of working and also an element of cost reduction to meet the budget we actually talked about earlier in closed. We're in the middle of phase 4. Lots of directors have been involved in running interviews, etc., and we're coming to the end. We have agreed with the board that by the end of April, beginning of May, we will have concluded that first phase of changes. I just want to put on record it's been a difficult time for the people in the ICB. There's a level of uncertainty, and I know some people will be at risk as a result of the process, and that is difficult. I just want to put that on record, Chair. The second thing then I think is just to make the board aware, and you will be aware at the last board meeting I referenced the fact that it was likely that there would be an ask from NHS England for the ICB as the organisation to look at itself and understand how it could reduce running costs. I mentioned it at our board meeting, and then within 2 hours the letter had arrived that evening. So, Chair, I've included the letter in my pack because it's a really important moment for the ICB, and you can begin to see what the challenge is. We are proposing that as an ICB we don't take this as a simple here 30% of cost equals 30% of posts and just salami slice. And you can see what we want to do, Chair, and we'll be working through this with both the executive team and partners, is take a fundamental look at what is the role and purpose of an ICB as an organisation within a system. The ICB in the organisation is not the same as the CCG. What is our role and purpose, and therefore, sorry, is there something?
Right, we've just been blinded a little bit, sorry, right, all of a sudden red lights.
Okay. So colleagues, you'll see in there what we're planning to do is really look at role and purpose. We're looking at functional analysis, and then we will be looking at what is the model of delivering the ICB services. And this will not be simply about an ICB, it will be looking at the system as a whole. And there may well be functions that we as a board would choose could be better delivered by somebody else in the system, might not need to be delivered at all, and actually looking at the relationship we have with other partners such as NHSE and asking what is the resource required to do that work. So you'll see our approach is to take an OD, organisation development approach, look at our strategy, look at our functions, and then really propose a new business model for the ICB, because 30% cost reduction cannot be achieved by salami slicing. This is a fundamental rethink of what is the role of the ICB in an ICS. Okay. And then the final thing then, Chair, in my update, I've just referenced obviously industrial action next week. And obviously we have plans in place. All partners have been working extraordinarily closely to get those plans in place. However, the reality is this will have an impact. There is no doubt it will have an impact on outpatients, inpatients, day case. It will also have an impact on the staff who are working, and it will have an impact on the NHS as a whole, Chair, and it is a considerable challenge. It is not a 4-day industrial action, it's a 10-day event, because it's across the whole of the holiday period, it's during the week, and then back into another weekend again, Chair. So that, Chair, is the 3 points of the update. I'm more than happy to take thoughts, comments or questions.
Okay, thanks, Shane. Any questions for or comments for Shane? Alison.
Thanks, Shane. I do like having the top few things in your head, but hopefully they'll on top of things, because then you'll have lots of retrospective that you've done. So I like that. Just in terms of acknowledging the process of change inside the ICB, one of the comments I made last time was having a proper evaluation from that process, which would be helpful for me. And I can see it in the timeline, which went up to May, so I just really where that was in that.
Yeah, we've had debate about whether the next phase is just stage 5 of, so we've had stages 1 to 4, or whether it's a completely different process. Either way, we need to learn on what's worked well and what hasn't worked well. And Joe Hicks, unfortunately, whose name is today, Chief People Officer, will be looking at that. So how did it feel for our staff? Did the process work, etc.? This phase is different from what we did before. What we did before was look at our functions and say, can we do those functions with fewer resource and fewer staff? This process is not that. This process is Do we need to do the function? And if we should we do it in the ICB or do it with partners? So it is a different approach. However, how do we treat our staff is something that we need to make sure we did it properly. Against it. I still think it's a huge challenge in an organisation that will take 30% of the cost out to deliver all the things we're being asked to deliver. But it doesn't contradict what we do, apart from that one line. Yeah.
Thanks, Steve. Any other comments or questions for Shane? Okay, in that case, Ellen?
Well, just a quickie. There's obviously some really important discussion needs to take place here, and I would have thought with other system leaders, and I just understanding how that process is going to work.
So we have begun the conversations with the other 6 ICB chief executives. We are doing a piece of work with NHSE, looking at how the 7 of us can work better with NHSE in the context of NHSE, who are also going through an enormous, I'm looking at you, Sue, an enormous restructuring as well. So we are looking at this as an issue of 7, and therefore you might end up in a situation whereby once we've gone through the functional analysis, there might be stuff that we do once for the Southwest as opposed to do once for an ICB. I mean, that's the kind of conversation we might find ourselves into. I'm not going to put any functions on the table at the moment, but the logic could be, should we do it once for 7, not 7 for 7? And I think that's one of the models we've got to be open to.
Okay, thanks, Shane. Any other comments or questions? No, in that case, I'll move us on then to the next agenda item, which is the role of the corporate parent. So I think, Joe, you're going to start us off on this.
I do. Thank you very much. And can everybody hear me okay? Because I'm conscious of the sound, and I was talking too softly earlier. But I'm really pleased that we've made time to talk about corporate parenting today and children, because quite often we seem to talk about, in our all age range, maybe discharge to assess and over-focus on older people or adults. So I think talking about our young people is fantastic and necessary as a board. So thank you for making the time. We have a responsibility in local authorities, whether we're officers or elected members, for corporate parenting, but actually that extends to our partners. So this presentation is purposefully challenging around how we are discharging that role in terms of ensuring that both from safeguarding but also supporting our care experienced young people to achieve their full potential. You know, what are we all doing in that space? And so that is the purpose of why we wanted to come and present to you today. This is a North Somerset presentation, but actually the challenge is across the NSSG. So we're representing all our care experienced young people across all three footprints. And I think the messages in there are applicable to all. I'm delighted to be joined today by Carrie Yates, who's my head of corporate parenting, but also, more importantly, Beth Swan, who is our young director and actually has drafted this presentation and will be key to delivering it and can really challenge us all, and is very inspiring in doing so, if I may say so, having heard this twice before. So I'll hand over to you to do the presentation, if that's okay.
I'm just going to say it from a university perspective, because UE has got quite a large number of care leavers as students. So it is that point. What would we want for our children and loved ones? And what wrapper do we put in place, recognising that their journey has been a different journey? And how do we make sure that they thrive and flourish and succeed? And it is everything from accommodation through to support services, through to the academic endeavour. And the whole thing has to work and be joined up.
And I imagine the
honest.
Yeah, absolutely. I agree with you as well. We need to trust us and more impact of our services.
helpful. I mean, one of the things that we've been talking about within the council around how we can help is how we can even create opportunities like apprenticeships that are ring-fenced for our care experience young people. So I think is large organisations that we lead, there are genuinely big opportunities to make a massive difference for our young people. So I suppose that would be my ask, as well as the raising awareness, which is really important, and the language that you've heard is so important too. But there are practical pieces of work that we could all commit to, which would make a massive difference. And I guess that's my challenge to all of us.
So Joe, have you had that conversation with peers across local authorities and then, you know, come up with some suggestions for us?
No, we haven't, because Lisa heard the presentation and along with me was very enthusiastic about wanting to bring it into the ICB. So we haven't actually, we've ended up coming quicker, maybe, and leapfrogged in a way some of the conversations that we could have had to join up initially. So we haven't had a CEO conversation yet around this topic.
Because I mean, there's great opportunities for role modelling, isn't there?
Yeah.
An opportunity for children in care. It's a great chance for us. Dave?
Yeah, thank you. Thank you as well for what was a fantastic presentation. And I think, as Joe said, actually, the work that you've talked about is going on in each of the other two local authorities, and we've all got action plans, and as councils we've all got our programmes of work to support in this space and young people with care experience. And I think it is a good opportunity, I think, for us maybe as CEOs to come together and think about how we can share and develop a joint action plan across the system in that place. We've quite often talked around this table around the workforce shortage that we've got, and I think there's a real opportunity to link our workforce shortage into the challenges that care experienced young people actually have in getting into employment in some cases, and I think there's a real opportunity for us there. I think the other thing that I was just going to mention is that within South Gloucestershire we're also investigating at the moment whether we can make care experience a protected characteristic as well, and bring some of the protections that come with that to our young people who are in care. So I think there's some real opportunities as a system we can learn from what everything is happening across the whole system and see if we can bring it together and join it up a little bit more. But fantastic presentation. Thank you very much.
Yep.
So I just wanted to say, the reason we brought it to the ICB board was very much about making sure that there was a raised awareness, because actually, you know, it became a very stark presentation at the partnership board, whereas I don't even think everyone across the partnership was aware, Joe. So I think it was about actually having that raised awareness within the ICB across all our partnerships to have that understanding. And I did think that we thought that was really important about bringing it here. And also it really does help when we're having conversations. So one of the things that I was thinking about, something that Beth said, actually what is our access policy? Because I know at the moment if you DNA twice, you're referred back. Actually, do we need to actually look at that? You know, simple stuff that actually starts to look at thinking about what our criteria are, how do we then change some of those processes that actually massively impact? Because not only do you miss 2 appointments, you then start back at the beginning. How do we then step those through? So it's those sort of things that I thought was really important to bring back here.
Okay. Thanks, Lisa. Deb?
So we had a conversation this morning about digital, and thank you for the presentation, it was amazing. I think one of your points was how can we engage you and how can you be part of that. I think that digital piece as we're designing the strategy, particularly the bits that are how do we create the kind of digital tools that people want to use to access health and care and interact and raise health literacy. So I'd really like to reach out to you as part of that. And then I think the connection with careers, etc. Having digital skills is part of, you know, for the future, is part of something that everybody needs to have. So if we can try and bring some kind of digital experience into that, I think it would be a really good joined up piece of work. So I'd love to get in touch with you on that.
Thanks, Deb. Alison and Sue.
I was going to pick up from the health outcome point of view, what Lisa's picked up, then Lisa's point, and I think with dentistry coming in as well, I think we probably need to think about how we can engage more with people who don't naturally want to come and get appointments and things, so I think there's something there. But I think
Sue? Joe, I think it occurs to me that you know, this is right at the centre of who we are, isn't it? It's about population health, it's about breaking the cycle for vulnerable people. But the point about ring-fenced opportunities, I don't know whether that's something you could engage with the rest of the chief execs around the table to look at what they might look like. And I think it'd be helpful to bring an update back to the board about who's committed to what. Because I think you know, amongst us, we account for 50,000 people working in Bristol, North Somerset and South Gloucester. There must be opportunities which will create some element of optimism for the future for young people and an opportunity. So it would be really good for us, I think, to do something practical like that as a board, even though we're quite strategic on a lot of things we do. That practical engagement, I think, it's likely to make a difference in lives. So, Shane, I don't know whether you have to add on that.
A couple of things. I chair the Regional Children and Young Persons Board, and actually the reality is it doesn't look at the corporate parent, doesn't look at children in care, and it doesn't look at the transition of children out of care. It looks much more at the health and issues. So actually it's a really great point. I need to bring this back into that Regional Children and Young Persons Transformation Board. I think the issue of employment and our role as an anchor organisation, I think we need to have a wider cut. So first of all, absolutely children in care, and then those who are having left care. But we have another set of questions about, you talked about protected characteristics. We have other people in our population that actually we need to make sure we can look at how we provide good, sound employment for their benefit and actually for everyone else's benefit. So I think we need to talk about children in care, we need to talk about corporate parent role, but actually something about the role as an anchor organisation in our society, which is much more than just normal recruitment. It's much, much more. And as somebody in my previous life who was corporate parent to 611 young people, in my previous life in Northern Ireland, it's something that we must take unbelievably seriously. Because the health inequalities tend to be focused around protected characteristics, and actually the health inequalities that come out of children in care can be quite extreme. Access to dentistry is a perfect example. So I think the idea, Joe, that collectively as chief executives we come together and we will absolutely present back to the board. And I think we should commit to challenges that we will do as part of our job on this board. And those challenges could be about employment, they could be about other things as well.
Okay, thanks, Shane.
Brilliant, thank you.
So make sure we capture that, Sarah. And then to Carrie and Bethany, thank you. You can see you've provoked some thought, and I think you'll have provoked some action as well. So it hasn't been time wasted. Actually, it's been really good use of your time, and I think good use of our time as well. So really appreciate your time today. Thanks very much.
Thank you.
Okay, the next item we've got on the agenda is Healthy Western, and I know we've got Paula and Becky with us. Shane, I don't know whether you're going to start us off on it. So this is the one that came to the private board last month as the business case, and then we asked for some work to be done, to be checked, and then to come back into the full board this month.
Thanks, Roger. So I currently chair the Healthy Western overall steering group, and as I say, we did bring the case to the private board. We certainly asked that we could look at a number of things. One is funding source, and one is an understanding of how it links to benefits, etc. We now have the full business case in front of us, and we're being asked today to approve that full business case. What I would say, in the knowledge that having approved the budget in the closed meeting, that in fact the resource is in the budget, okay, which we didn't have last time. So it's in the context of the resource being in the budget, do we approve this as the business case? So, Chair, I'm going to hand over to Paula and see where we go from here.
Well, that's really positive, Shane, really positive opening remarks. So thank you for that. I just really wanted to take some brief moments because everybody's had the opportunity to consider this case in detail on a number of occasions, which is a really good thing because it's a very robust case in our view. But I think it's important to note that the case definitely does represent both a significant and symbolic step towards realising the vision for Healthy Weston 2, which is about ensuring that Weston Hospital is a thriving hospital able to provide acute care appropriate to the needs of local people. And those local people have some of the highest health and care needs in our system. I think, as we've discussed before and was really important to draw out, the case also provides the platform for the place of Weston to really be a national exemplar for innovative and integrated services, where I genuinely believe that we can have hospital, social care, community teams working increasingly as one. And we're having those conversations, including the concept of one Weston workforce with all of our partners. It's a very live discussion. So you've had the opportunity to consider the case in detail. I actually have to say thank you because I think the robust challenge to say how transparent can we really be about the benefits that this investment will bring was an important one. And in that regard, those benefits will bring improvements to urgent and emergency care, not just in North Somerset, but across all of our system. The Appendix A, the benefits addendum that has been presented following the closed board session in March, sets out in detail both the qualitative and quantitative benefits that can be measured, that can be tracked for patient safety and quality, for ED performance, overall measures for effective patient flow to get patients to the right place first time, and significant financial savings of over 4 million from reduced use of agency staff and reduced use of escalation capacity. The other thing I want to say is that this board can be confident that these benefits aren't just written down, they are deliverable. Why am I comfortable to say that? Because there is clear evidence of the benefits that have already been achieved and secured at the hospital. And I am going to give you a couple of quick examples. Since the merger that created University Hospitals Bristol and Weston in 2020, our registered nursing vacancy rate has reduced from 26% to less than 2%, and it's on track to be 0. I'm nearly afraid to say that, but it's below 2% as I sit today because I checked it today. Over the last 18 months, we've been able to increase the substantive middle grade and consultants ED staffing by 6 full-time equivalents. We've recruited some hard-to-recruit 2 posts, such as care of the elderly consultant. Since October last year, we've increased the number of people being able to be treated in same-day emergency care from 2% of ED attendances to 13%, and that has impacted on improved ED performance and significantly a reduction in those patients having to be diverted away from Weston Hospital to hospitals in both Bristol and Taunton. So that's a real quality of care issue. We have revisited the funding profile. I was going to touch on that, but I won't, Shane, because I think we've worked hard to secure agreement, and that will be reflected in the 23-24 operating plan. I'm going to ask Dr. Maxwell to just touch further on the patient safety and quality benefits, because that's what this case is fundamentally about.
Thanks very much, Paula, and thanks, Shana and Chair, for this opportunity to come back and speak to you. I know that a lot of you have heard me speak before, and I know that I've been here before and that you've got a lot of the information in front of you, but there are a couple of safety and quality benefits that I'd be keen to draw out for this board. I think we all are very aware that delays to timely admission from the emergency department causes patient harm. And actually, there has been some publications on that, driven actually by the National Girth Leads and the late Cliff Mann, who worked on in Taunton from this region as well, which showed that increased length of stay in the ED increases mortality. And what was drawn out of the publication that they published just last year was that actually the biggest increase in mortality is those patients that wait 6 to 8 hours for a bed from the time they arrive in the emergency department, and that increases by 8%. So for every 82 patients that arrive in the emergency department and wait 6 to 8 hours for a bed, that means there's one excess death. Now, what does this mean for Weston? Well, actually, when you look at our figures, our improvement we've done already, we have translated this into a figure for Weston, and we do believe we can achieve this by implementing Healthy Weston 2, and is actually a reduction in 60 deaths per year in the Weston Hospital, which is quite a significant number, and that's by all-cause mortality up to 30 days, so everyone's clear on what we're talking about. I think on top of that, we all are very aware about the population in Weston. Last time I was up board, I did speak about the segmentation and the fact that there is quite a deprived population that the Weston Hospital serves. But those population also rely heavily on healthcare services, take up lots of non-elective beds and length of stay from that point of view. But they have also been shown to have the most ambulatory sensitive conditions, and by that I mean conditions that can be treated at home. And what the Healthy Weston 2 model does is, by investing in the GEM service, investing in frailty, and working with our locality partners in order to get those patients and get them the best care at home, results in more patients being discharged, better outcomes for them, reducing deconditioning, and actually over a better patient safety profile, which actually suits the needs of the population of Weston. I'll hand back to Paula.
So I think that's what we wanted to summarise today. I know you've had the opportunity to ask questions before, but hopefully the additional information that we've been able to be transparent about in terms of the benefits adds to the confidence that this is something that can be delivered and delivered at pace.
Thanks, Paula. Thanks, Becky. And a lot of detail in there and lots of fantastic movement forward. You've heard me say it before, but being sat around the table 5 years ago at Weston and looking at where we were and where we are and where this signals that we are going demonstrates us coming together as a system to look at healthcare across our whole region. So it's fantastic. It's fantastic news. And I think I'd be surprised, well, I'll open it up for questions, but I'd be surprised if anyone around the table would not say this is absolutely the right thing for us to be doing, so it's commendable. I would just finally just say, I think he may have gone, but Graham, who's one of the public governors for University Hospitals Bristol and Weston, was sat at the back of the room, and I suspect, Graham lives in Weston, I suspect if he told the story about where we were to where we are, that would be incredibly compelling, and you'd realise that the citizens' view of where we were and where we are and where we're going is remarkable. So, yeah, thank you. But questions, comments, Steve?
So not a question, because it's all been answered in the documentation. So I think this is transformational. The journey that we've been on, and wearing different hats in different places for 5 years, is really getting to the heart of what Weston deserves and what we need in the system. And it's great to see it. And I have to say that the journey that I've been on with Weston is sort of almost 20 years, because when we had strategic health authorities, we were scratching our heads at that point as well. So this is transformational. It gives, I think, a huge lift to citizens in the Western area, but beyond Western area. This is owned by the system for the system. So, well done.
Thanks. Rosie?
Mine was the same sort of thing. I had the opportunity to walk around Weston with your Division Director of Nursing last week, and it just feels a completely different place. The energy of the teams, the ED matron was fabulous, and being on call, I watched our figures, and actually the kind of the ability now of the team to kind of manage flow through is so much better already. So I think that just kind of shows us how far the team has come and how important it is for us to keep supporting the progress. But amazing job so far, so absolutely we should continue and support. But great to see such a positive atmosphere on the site.
Thanks, Rosie. Ellen, Joe, and then Alison.
Supportive, so thanks for the presentation and last time, so sort of equally sort of impressive. I suppose my question, first of all, the 26% down to 2% vacancy, how are you doing that when other areas are struggling, and is there anything as a system that we can take away from this blueprint of not just the vacancies but the whole system you're putting in place that could be replicated in other parts of the system?
So in terms of the RN vacancy rate, I mean, she will have chapter and verse on this, but I mean, a significant amount of that has been as a result of our international nursing recruitment approach. I think what we've been able to do is also ensure that alongside that a focus on retention, both of the international recruits who come to work with us, and we want to be part of our family, our work family, but also ensuring that we start to create a pipeline. And that fundamentally actually goes back to even the role of corporate parent and our role as, wider citizens in an anchor organisation. How do we start to create opportunities for the workforce of the future? But in the here and now, the reduction has been both a sense of there is a future for Weston Hospital. It's a vibrant future. It's a future with different career pathways. That all helps with retention, combined with some of the international recruitment. In terms of the replication, every place has its own nuances, doesn't it? But, coming from the same background as Shane, my heart is very much in integrated services, and I fully believe that the place of Weston, with its scale, its community, the number of partners who come together regularly, that the area of Weston and in North Somerset, we can sort of provide the basis of how do we do really good integrated services and be an SSG.
If I can add, I think one of the differences I saw visiting most recently is staff being really valued and really listened to. And so whilst we get the kind of pipeline of people coming in, the critical bit is then people feeling really supported in the workplace, and they clearly do.
Thanks, Rosie. So we've got Joe, Alison and John.
I just wanted to say how chuffed I am that it's coming together and happening now. I mean, it is transformational, and particularly given some of the challenges some of our residents face, as you've outlined in terms of that segmentation. And just say how great it is to hear this presentation on the back of the localities presentation, because that piece that you were talking about in terms of systems working and that sense of community and partners working together to transform, it's just really great to have both of those presentations happening this afternoon.
Thanks, Joe. Alison?
Yeah, absolutely brilliant. Also, I think we've sat on many tables over many years, and this is just absolutely brilliant. And the examples you've given about tangible difference, and even the R&D filling those will help it to be built up and word now. So let's do this, so you can see all those things coming. Ellen asked the question I think I asked last time about transferability, and I think there is something about it might not be a lift and shift, but how can you capture some of the principles that make this integrated model work, which we want to hold of for any other one. So I just think that something that I think that might be worth it something, rather than saying you can just lift and shift less and just pin it might not, but there is something about all the pain that's gone through and that and setbacks and without creating a new legacy, that's something else. But thank you very much. I'm delighted to be here to hear it get into this one, and I've got confidence for you in words which I think it's really in place are always really good words, and I think I've got confidence to reassure that we're going to do it. So thank you to you and everyone who's on the board.
Thanks, Alison. John?
Great, thanks. It's not a question, it's just an observation. I challenged you on the benefits, and I just wanted to say thank you. I think you've really taken that on board and done an exemplary job. It's really, really good to see, so thank you. And not on as long a journey as Steve, but I remember sitting over that side of the room about 3 years ago in CCG in much more challenging circumstances, and it's really, it's great to see where this is now gotten. So thank you, well done.
Thanks, John. Sue? Okay, thanks. So, Eugene, perhaps if I bring you into for the last word, but I'm hearing there's a general consensus about where we're at with it now. So, you know, well done. I mean, it's a huge step forward. But Eugene, I don't know whether there's anything you'd like to say as the CEO for Western.
Well, Jeff, I think what I want to say has already been said.
Good.
But I think one of the things that is different, and Paula and Becky won't say it, is leadership. I think the leadership that's been provided at Western before they got there and what they've continued to do is what's sustaining a lot of the things that hitherto have been pipe dreams. So I think the importance of that should not be underestimated, and definitely our thanks for everything that they've done and will continue to do to deliver this.
So thank you. So we're being asked to agree the full business case. Is there anybody who's not in agreement? Okay, so I take that as a yes. So thanks very much. Thank you to see you both again, and keep up good work.
Hey, thanks, and we'll pass it on. This is not the work of Becky and I by any means. There's a very large group of people involved, so thanks. That's really positive. Thank you.
Thank you both. Can I move us on then? Dave, I think you've got the next agenda item. Yeah, and of course, yeah. Well, you'll introduce Tim, won't you? Yeah, it's over to you.
Building on the locality presentation, building on the last presentation, a triumvirate of Western presentations today, and I am also delighted to present this paper here in Western, as it represents an opportunity to significantly improve the estate for the delivery of primary medical services and community services for one of the most challenged areas in our health economy, and an area of very high health inequality. So it's great to have got to this stage. I'd like to introduce Tim, who's our Strategic Estates Manager at the ICB, and has been the brains and the driving force behind this business case for many years. And so Tim is here to answer any kind of questions of detail after my introduction. I am presenting this on behalf of Sarah Truelove, who unfortunately can't be here today, and I'm bringing this further to recommendation from Finance, from the Fed Committee to approve, or to recommend for approval from the ICB board. And the paper, as you'll have read, seeks board approval for the full business case for the relocation of Graham Road Surgery in Western to the proposed purpose-built new development at the Western Rugby Club, which I had the pleasure of driving past this morning as a context setting on the way in, as I'm sure many of you did. Just in terms of a very brief introduction from me, this has been a long journey to get to this stage, much as the Healthy Western presentation previously. The capital programme was actually instigated by North Somerset CCG, which predated BNSS CCG, and now we're here today. As you'll have seen through the papers, initially capital bid was submitted for this development back in 2018 through what was called the STP Wave 4, and an outline business case for this development was approved in July 20, and planning permission approved in November 2022. Further to hopefully today's approval will then be submitted to NHS England for regional approval, with ideally a construction plan start date in October with a 2-year build plan. As you'll have seen, the proposal is for a new fit-for-purpose general practice building for the Graham Road Surgery in the central part of Western. The current building is very low quality. As you'll have seen from the paper, the Peer Health Primary Care Network is the top priority for investment in primary care estate across BNSSG. And the proposal is for an integrated primary and community care development with Sirona, developed by an organisation called Studio Hive. We have, as the previously stated, submitted and have access to a £3.2 million capital funding subject to approval of this business case. Sirona will occupy the upper floors of the building, and that's subject to separate funding and not within the scope of this FPC. The paper sets out an extensive history of ultimately the choice of the site of the rugby club for the development, And I won't, you'll have all read that, and I won't labour that point further. As I said, in terms of funding, it's a blended funding model, including that 3.2 million of STP capital, prioritised system capital, which has previously been considered here in terms of that system prioritisation, and also the revenue budget that we have for the rental, which is currently used for the Graham Road surgery. There are a couple of risks which I draw attention to, which none of you would be surprised to see in terms of market uncertainty and inflation. As you've seen through the mitigation, in terms of market uncertainty, we were highlighted to potential uncertainty for the developer back in the autumn, but we have subsequently received confirmation in writing from the developer in January of their intention to proceed, so that is currently mitigated. In terms of inflation costs, soft market testing has been completed, which indicates that even despite the inflationary inflation that we have all seen, the fit-out costs are in line with the kind of top level of what we're expecting to see. So that is also currently mitigated. And there is a risk around the STP funding. There's that 3.2 million at a deadline of the 31st of March. So consequently, needing to seek approval today to enable that we can then utilise that cash. It's been approved by business cases that previously received the support of the Health Overview and Scrutiny panel in North Somerset, and as I said previously, recommended from the Fed Committee for approval here today. That's probably what I'll say in my introduction, but seeking board approval for the procedure.
Okay, thanks, Dave. Any comments or questions? Steve?
Just a comment, Chair. I mean, this was considered by the Fed. It's obvious we should do it. It's frustrating it's taken so long. And there is something to learn about if we're really going to move at pace on some of these things, we've got to find a better way of processing this through in the future. There's an awful lot of work that's gone into this, and we just need to move this through as quickly as we can and make sure we secure that 3.2 million. So I'm hoping that NHSE will do the right thing and support it.
Okay, thank you, Steve. John, Ellen, and who else am I missing? Anyone else? Oh, sorry, Julie. No, Julie was first, sorry. So Julie, John and Ellen.
Yeah, I just want to say absolutely it's been a long time coming, and this is really exciting, and yet again it's another real example of where this is not just about a building, it's about how we're changing the model of delivery. So Dave mentioned, Serona will lease accommodation, and just for reassurance, that's been through our own board, and subject to the final commercial bits, but definitely approved in principle. It's in our financial plan, and it just all fits together now about that closer integration of community, primary care, thinking about what we heard about the hospital and then the partnership. Our facilities in Weston are some of the worst that we've got across our patch. They are pretty appalling, and then in some parts we've just got nothing. So where we have got something, it's really poor. In others, staff are literally working out of their cars, or they're having to travel back to Clevedon or wherever to find an office space. So this is going to be quite, massive, significant change and improvement. So really support it.
Thanks, Julian. So it is a positive move forward. John and Ellen.
Thanks, Joe. It was just to welcome and support everything that's been said. And the thing that I think is really interesting and helpful is around the wider regeneration of that area that this is going to be part of. I'm just thinking about our social and economic development purpose. This is something really tangible that we can put in that column. So I very much welcome this support.
Thanks, John. Ellen?
Yeah, mine is sort of very supportive of the project. My question is more about the construction charges and costs, and how soft, I think you mentioned here that soft market testing exercise is taking place. How soft is that? And what's in place if those costs were to escalate?
So the developers undertaken that exercise, and they've had a range of quotations back, and are confident that the scheme can be delivered within those, and have given us a not to exceed price on the rent of the building based on that. So on that basis, the cost is fixed in terms of the rent we expect to receive. Of course, if inflation and the market changes such, I think inflation clearly has been an issue, a big issue on this project the last year or two. What's really been and at least as big issue has been the uncertainty investors have faced since the autumn budget that took place, where investors closed their books. I think at the moment that has been a bigger risk actually than, I think the inflationary costs are understood within the market now, and actually construction costs have been levelling out, but it's just around securing those investors to deliver, I think, is potentially where, and actually them expecting higher yields on their investments. I think that's caused cost pressure. So we're just managing those issues through over the next month or two while that is fully procured. But I think those risks are understood and are mitigated well.
Looking at the floor plan, an old friend again, I haven't seen him for a while, but yeah, this project is brilliant. I wanted to say to you that Tim has been really good throughout all this, there's a lot of credit for being here. And what you said also, what Steve said is actually, do we know why, without again, do we know why it took so long, and have we got something that we know we can put in place that's going to take so long? So there is a bit about proper learning from this, because it has gone on for a while. But I just want to say, definitely support it.
Thank you. I think we've had a number of challenges in this project, but two really significant ones. The first one was trying to actually find a viable location and site in the centre of Weston. Today I parked in the Carlton Street car park, and I've walked here, and it's like going down memory lane, coming past all the retail units and the different locations we actually did tours of and tried to find a viable site. And I think there's 17 different locations we surveyed, and within those there are several different options within them, including the Sovereign Centre. We had 3 or 4 different permutations. We're trying to find a location in the town centre that would deliver the size of facility we wanted to the modern, fit-for-purpose standards for health that we required for the people of Weston, with natural light and with parking and access for patients. That was really difficult. That took almost 2 years, actually, of, every time a new building came onto the market, we'd be there. Marks and Spencer's, when that came onto the market, we were there. TJ Hughes, when that came on the market, we were there. So that really added time. And I'm not sure how that can be shortcut. You have to deal with what's in front of you and what's available, without compromising too far on the output, I think. The other one was COVID and what that did to the market. So originally the intention was that this would be a 5-storey building, GP space on the ground and first floor, but that it would be office space above commercially let office space. Well, COVID and the working from home revolution meant that office space in Weston wouldn't be marketable. So the developer had to do an awful lot of rethinking of the scheme. And that took quite a bit of time. And very fortunately for the delivery of the scheme, but also for the healthcare in Weston, Sirona opportunity became interested, and that has enabled us to deliver an entire building for health. So I think no doubt there are things we can learn and do quicker, and some of the hoops we have to jump through with the NHS England business case process, particularly for a scheme of this size. I think there's something about proportionality there, which does tie it up unnecessarily. But I just think there were some existential challenges we had on this project that there wasn't really a way of shortcutting over that period of time.
Thanks, Tim. John, and then perhaps Shane, the last word.
Yeah, really positive, really supportive of the programme. It's just an observation was, despite some of what we just heard, the opportunity to access these kind of capital funds for future projects is not clear to us at all at this point in time, and I think the board should sort of note that. So important to recognise this is a high priority project and support it, but yeah, it's not going to get easier to do this stuff in the future, and yet we've all just heard how positive it can be and how transformative to care it can be. So that's a risk that the board needs to kind of own and manage going forward, particularly around primary and community, capital funding in the public sector generally, but particularly around primary and community estate is really, there isn't an obvious route to accessing it.
Thanks, John. Joe, do you want to come in on this?
Yeah, just quickly to thanks for the engagement with the council. There's been an awful lot of joint working around that from a placemaking perspective as well as from a health perspective, just picking up John's point. So, yeah, conscious that you've engaged a lot with the overview scrutiny in the same way actually predecessors on the previous item have as well.
Okay, thanks, Joe. Jane?
Yeah, I just want to, it's not so much a question, it's a reflection on the last 4 board items and how they come together to actually meet what we're really about as an ICB, which is improving population health, reducing health inequality, value for money, and social and economic change. And if you think about the combination of what we just heard, we heard from Rosie and Andy, what we've heard in terms of corporate parenting, what we've heard in terms of Healthy West, and what we've heard in terms of the Rugby Club development, that's exactly why we exist. And it's just, I think today has been the last 4 pages, a real footprint of what we're trying to do as an ICB. And actually, we just agreed investment of well over £5 million into the Western area, which we've already identified as the area that, from health inequalities that we need to address. It just is, I think it's a reflection of the value of all of the parts coming together to actually start to make a difference in line with what the ICB is trying to do.
Thanks, Shane. So we're asked to agree the full business case. Any dissenting views? No? Okay. Shall I just suggest perhaps we take Deb's update on care traffic control and then pause and have a quick cup of tea and a leg stretch for 10 minutes. The other items remaining, I think we'll move through fairly quickly. So we were anticipated to finish by 3:15, but I think we'll finish before then. I think we'll finish before 3 o'clock. So even with a 10-minute break. So Deb, do you want to just give us an update on where we are with care traffic control, and then we'll have 10 minutes.
So, for most of you, and I think Stephen, I couldn't find your email address, so you haven't, you will have a little email that's just popped into your inboxes. If you haven't already signed up for Care Traffic Control, it was just nudged you in your inbox. And our mission is that by the time we all walk out here today, maybe when we go to coffee, you will have it on your phone and you will be able to see the service, and you'll be able to, at the touch of a button, understand what's going on across the system. And as new pieces of information go live, you will be able to see those pop up. So we'll have that shared understanding of what's going on in the system. What we wanted to do today was to tell you about what we can do. So I'm joined by Keith Robertson and by Zilla Anderson, who is from Faculty AI, and Keith is our Azure Care Lead, who works in Lisa's team. And what we've been doing is, as we said to you last time with Care Traffic Control, we are moving where we were with our Alamac service into our new service, and that's what you'll see, and Keith will talk to you a little bit about that. We have also, which is a little bit below the waterline, but I think it's really important to flag, we have now in-sourced all the information that we used to source in the Alamac kit bag is now in-house in our internal BI servers inside the ICB, so we have access to all that data and we are doing that piece for ourselves. What we wanted to do today was give you an update, tell you what's upcoming. Kieran Flanagan, who's our clinical lead, isn't able to be here today because of clinical duties, but there is a bit on harm, which I think I will cover off at the end. Is that how we planned it? Yes. Perfect. But so I will hand to, we haven't got any slides, you've got the papers. We don't need to read through all the papers, but if you want to pick up the key points, Keith and Zilla.
Thank you, Debs. So I wanted to cover where we are at the moment with the rollout. We had in a previous system 150 active users, and just to give a flavour that we've got over 150 with the current system after we launched this week, and we've propagated and got more interest from the system, so we're targeting another 150 users as more on-call teams from across the system are now starting to access this and get access to more system data. So we've successfully launched this week. And I'm just going to cover the next month or so of what we're expecting to release and launch within the system. So what this does is building on or increasing the building blocks of what we need to reach our ambitions for the whole Care Traffic Control Centre. And that basically is the covering of or adding more data to our systems so that we can use that intelligently to make informed decisions. So over the next month, by the end of April, we are launching with 111 our 7-side urgent integrated care live data, so that will be coming shortly. In addition, we've also got our mental health colleagues going to provide us with live Section 136 suite data. So within the next couple of weeks, next month, we are expecting some immediate launches to that. In addition to that, we're currently scoping, and we've got specifications from primary care. We'll be adding primary care data to the live system. So that would give us previously, it's been seen to certain partners, but not on a wide-scale picture, the visibility of whole system flow within more partners. In addition, I think Debs has mentioned we've in-housed some of our data already. We are using the data as we currently see as a seamless transition, and we've used it in operational meetings. So it has been like for like so far. What we are starting to do as well is launch that nowcasting suite of tools that we've developed with our modelling and analytics teams, and that's been used primarily at this function between the ambulance and the hospital handover function of our system. But the capacity, and within the covering paper we've touched on length of stay and improvements and discharge, which is relevant for all of our system services that we're excited to launch with faculty. So we've split it into a phase 1 launch, which is a like for like, and I'm just going to hand over to Zilla now from faculty to talk about the next exciting stages.
Thank you. It's lovely to meet everyone. For those of you who don't know, I suppose Faculty AI are, we're an AI company, and we are supporting you, BNSSG, with your ambitions for your care traffic control centre. For us, as you say, phase 1 was very much about supporting you to produce your dashboard and enhance your data and build your data foundations for success. And then phase 2 is very much about helping you to use that data in a way to generate insights, understand connections between data points, and therefore use it to help individual users drive better, more informed decision making and collaboration across the organisation. It's something that as an organisation we've done with lots of different organisations. We're really, really excited about working through that with you. The key ambition we have is providing that line of sight for individuals across BNSSG as they move through your system, and to be able to provide that at both a system level, an organisational level, and also a service level, so people are able to understand what's going on within their own organisation, whilst also being able to see what's happening in other organisations, with view to be able to make that collaborative decision that helps improve patient outcomes. I think probably the bits that are probably most helpful for you to know at the moment is, as Debs and Keith alluded to, it really does start with building the data foundations, which has obviously been ongoing for a while, and that's what's enabled us to kind of launch within 4 weeks the new dashboard. We're also building new foundations as we go, and we'll continue to do so. So there'll be points at which new data feeds come online. We are working and building on existing BNSSG data assets, so the harm work that Kieran has been doing, the nowcasting work that Rich Wood has been doing, and also the user research that's been ongoing across the system already. So again, it's definitely not about duplication, it's about kind of bringing all these things together to make sure they're connected and all the insights are being derived in the most usable way possible. We're working towards initial product release in October, and we would love to be doing kind of interim product releases kind of from end of May, beginning of June. So there will be bits and pieces being released to you. We really do love feedback, and we will make sure there's some comms around those as they happen, so people are aware of what's happening when, and what they can expect, and also what can also be evolved as people start using it and testing it. As Deb's alluded to, hopefully you've all got access to it.
I've got a few messages coming back saying it won't let me. No.
Okay.
So I sent the link you sent me yesterday, and that's not working. So
Fine.
if we
Okay.
can get that sorted today.
Yes, fine. There is there's an email from helpfully no-reply@faculty.ai, which may well be in junk mail or have been deleted. So that is the email you're looking for. We resent a few this morning that may well be therefore at top of inboxes. We're planning to
sort it out over coffee.
Yeah, we were planning to resend them all anyway. So
we'll have access before we leave.
Yeah. So I guess look out for that. We'll make sure everyone's got access to it. We'll be conducting user research. Some of that's been identified already. Building on the work that's been ongoing. If there's anyone or anything that people are really, really passionate about, make sure we know so we can organise it. And as I say, the product release communications will make sure are distributed so people are aware of what's happening when and why and what they can expect. And I suppose just a final note, we've been able to help launch your replacement dashboard within 4 weeks because of the really strong foundations and collaborations that already exist. And I know there's lots of work ongoing to get even more data ready for use, which is really, really fantastic. So I'm kind of, I suppose, as a team, we're really excited to work with you to get to the end point, and look forward to keeping everyone updated.
Perfect, thank you. So the thing I just wanted to draw people back to was a piece of work that we talked about, which was about understanding harm. So it's not just about understanding the activity across the system, it's about understanding what's happening for people. So Kieran Flanagan's been working on an approach to how we start to indicate harm through data dashboards, etc., but being able to understand what's going on across the system and trying to be able to understand not just the harm that may be happening in the ambulance that's waiting, but also the harm that when we put somebody into a bed and we can't get them home and we haven't got the right rehab, or the harm that's being caused because somebody went into a hospital in the first place and could have been supported in the community. So the piece of work that Kieran's been doing is in your pack, so you can kind of see the process that they've been going through. And I think the work they're doing is quite groundbreaking because they're starting from the beginning. The thing I said to Kieran yesterday was, if you were here, what would you want the board, what few sentences would you want the board to understand? And she said, of clinicians at the front line, so she's a consultant in NBT, the clinicians at the front line are really excited about this landing. They are connected to it. They can see not just the depiction of harm, but the whole of care traffic control being able to game change the way in which they think about resourcing and the way in which they think about managing this. We haven't yet got to our social workers, and I think that would be the next step, to start to think about how can we help make sure that care teams, safeguarding teams, and everybody else has got the same capability. But I think it's really important that we're not just thinking about activity levels, we are also thinking about what's happening for people. And so I think just making sure that we continue with that clinical leadership into next year is going to be really, really important in terms of this. And then just the one other thing that you might have seen, Shane's picture associated in the HSJ with this. We've been accredited with being one of the first systems that are starting to look at AI and the capability in working with faculty as a partner. One of the things that we just wanted to make sure that people are aware is that we are not spending any more money on this than we have been spending on Alamac. It is really important that people are aware of that in terms of the spend as a system. It is the recurrent cost that we were spending on Alamac and our systems, and that continues to be the budget. There has been no change to that, and I just wanted to make sure that board members were all aware of that piece of information. Because
it was misquoted.
Looks a little bit more grandiose than it actually is. So the figures are not quite right.
Okay, thanks, Deb. Any questions? Alison?
Yeah, thanks very much. I'm really pleased that harm bit. I think when you start off, especially how you balance risk across the system, it's a start of the conversation. So this helps us to get to the start of what needs to be discussed. Just looking at the risk implications, there are no risks outlined. One of our users don't sign up. I don't get a sense that this jumps in as a cultural change program, therefore this is people don't go. You've said the impact is low, the likelihood is quite high. So I'm not sure if this is an opportunity or not, but I guess now that we've got the system, we need to maximise and optimise it so that it becomes the system. So I just didn't get a sense that the mitigation for users not signing up was send them 4 emails and then we'll chat to them and send them an alignment transaction. This is a different way of working. I didn't get a sense of that.
No, I think you're right. We need to do a lot more work. One of the things we talked about on the board yesterday is that our benefits, we're currently doing a kind of Hoshin Can React matrix around the benefits so that we can really be clear on what demonstrates and depicts success with this. So at the moment we've got what we often do is have quite generic high-level benefits. There will be greater efficiency. What we're now doing is taking it to the next level to say, we will start to look at the baseline. So remembering the position that this started in, which was, we asked people, what will help you make better decisions across the system? And universally, all the people that are involved in EPRR and daily flow said, if we had information across the system, we would be able to make better decisions. So now we need to do that baseline that says, before you had all the information, where are we, and after, so when we get to the full deployment of October, where we are then, so we can do some interim evaluation and actually really understand what the impact is. So I think you're absolutely right. There's a piece of work to do to make sure, and then we start to think about the risks of success start to fall from that. So I think it's a point well made, and we need to sharpen that up.
Thanks, Deb. Any other comments or questions? No, so we're being asked to acknowledge the award of the contract, obviously as Deb has just gone through, and then endorse the way forward on this. And I think we should get a regular update on this, because I think we set this out some months ago and it shows good progress. So is there any other points anyone wants to make before I break us for tea? Okay, so I make it just kind of to 1:15. If we not be sat back down by 25 past, and then, as I said, I think we should probably be finished by 3 o'clock. Okay, thanks so much.
Thank you.
Thank you. Thank you everyone for your time. Move us on then. We've got a couple more items before we finish. The first one is the paper on acuter collaboration. We asked for this to be brought as a regular update to the board to get a sense of the work that Eugene and Maria were doing around the acute collaboration. I think the report's self-explanatory about where we're at with it, but Eugene, I don't know whether you want to mention any points on it at all, or maybe Shane, whether you want to as well.
Well, I think, as you say, this is just to keep the board abreast of what we're doing in the Provider Collaborative, which is in some ways a precursor to the health and care improvement group around acute hospitals. And you've got the list of activity. I guess the most important one is around the joint clinical strategy and how it will start to shape the way in which we deliver and redesign acute services now and into the future. So at some point we will want to bring the outputs of that. So we are on track for sign-off around the 20th of April. We will want to ensure that we engage our regional colleagues and indeed ICB in terms of emergent thinking around that strategy and what we will need to do going forward. And therefore this is just almost a prompt in terms of when we schedule the next more substantive discussion that the board may want to see around this. So happy to take any questions on that, Chair, but the report is as read.
Okay. Thanks, Eugene. Shane?
No, Justin, just to reinforce, the joint clinical strategy is the key linchpin in this whole process, and it's on track to be presented at the end of April. And that's the way I'm putting it, Chair.
Shane? Julie?
Yeah, I suppose it just makes me think about, at the right point, how we also make sure that although it's an acute collaborative, if we think about the clinical strategy and the shift to community, and the only way we're going to make the shift to community is collaborating because of the risk and the oversight. You know, if we're going to have more specialties in the community, how does that work? We're seeing it play out in stroke, in terms of the role of consultants overseeing some community. So it's just clocked something for me that actually at some point it'd be good to bring our strategies together, because Ruth and I have been doing a lot of work on community and primary care strategy, and I just wonder when the time's right, Eugene, so we can talk about that, about having a joint discussion. I know there'll be bits of this that are very, very acute. But
Absolutely agree, and I think in my mind there is something about how we right-size the way in which we deliver acute care in order to be able to free up some investment for other things. So there is a point where we will start needing to think about that collectively.
Thank you. Yeah.
Okay, thanks. Ellen?
Yeah. I think that's a really important point, actually, and be interested to understand when that will actually happen. So what is the roadmap sort of further out, really? So when Eugene, would you and Maria expect to be sort of collaborating more widely? Is that sort of in the summer or?
Not yet. I think what will be really helpful is if when we come with the clinical strategy and the outputs, I think a lot of the interdependencies then come into play. And we may well want to do a bit of a workshop type event, Chair, just in order for us to be able to see where the crossover is and the opportunities for us to do things differently across the system, just not in acute services.
Okay, I think that follows on from my conversations about what acute collaboration and collaboration as a whole looks like. But Ruth?
I think it sounds a lot more final than it seems, because at the moment there are 4 specialties that we said we can do better, and therefore, if we are right, can we start pulling together the work and the activity that gives us the evidence that we can do better? And I think at that point, in terms of those 4 specialties, that's when we would want to have wider engagement.
But I think it's a point well made, because we do know that within our acute setting, two big hospitals, there's an opportunity to perhaps move further and faster. And so that does need a focus. But, you know, Shane, I think it probably sits with you really as to timing when we broaden that discussion to make sure that both Sirona and One Care are brought into that conversation.
And I think what's important, first of all, what the clinical model looked like is new clinical models in acute, removal of duplication, variation, looking at how you do it across two sites. There is a bigger conversation to be had pretty quickly after that clinical model has been produced to ask, well, what does it look like to have a BNSSG collaborative as opposed to an acute collaborative? Okay? But we started with acute collaborative because that was the point that we were looking at, the potential for removal of duplication and the reduction of variation. I think it is a conversation this board needs to get into, to ask the question, what does a BNSSG collaborative look like, which is not acute? Yeah. You have.
And we will maintain this as an agenda item for a regular update, so we can see what progress looks like. And so I think this will prompt that conversation month on month, Shane. Yeah. This is just for noting for an update. Is there any other comments or questions anyone would like to make? No? Okay, thanks. So the next item is the scheme delegation. And this is brought about from us taking on pharmacy, optometry and dental from the 1st of April, which obviously requires the change to the schemes of delegation. Shane, I think it's for you to talk to. I don't know whether you or Sarah are going to...
Well, I mean, I can certainly choose it, and obviously Rob has been heavily involved, but in simple terms, we all know scheme of reservation delegation identifies the role the boards will undertake and what we will delegate to our committees. Two major changes there. The delegation of POD, those pharmacy, optometry and dental, which obviously happened the 1st of April, means we need to change that scheme of delegation to take into account primary care commissioning, etc. So that's the first big change. A lot of this has been standardised. I think the best way of putting it across all of the Southwest to allow us to do that delegation. The second major change is around corporate policies. Obviously, as we created the ICB, we inherited a lot from the CCG and the way the CCG worked. And one of the areas that is in the scheme is this idea that all policies, all corporate policies, should come to the board. And what we're changing in the scheme is the fact, you know, there are many policies within the ICB, whether that's to do with employment or health and safety, which actually should be delegated within the ICB. I don't think you really want the board choked up chair with us bringing every time we revise a policy within the ICB. So they're the two major changes about how we delegate. I don't know, Rob, you want to add anything else into that?
And just some examples of the policies. So there's a difference between the statutory policies that would come here for, you know, disciplinary, grievance, etc., that we would have, but assured through the People Committee before they came here. So hopefully it will be a relatively straightforward item for the board. But then policies, just for example, like flexible working or hot desking or what have you, which are probably better described as operational policies that I would imagine that this board really wouldn't want to be tied up with, obviously wanting to know that it's been quality assured on its development journey through things like the Corporate Policy Review Group, but with the ask that delegated authority is to the CEO and the Deputy CEO.
Sorry, yes, and just to note that there are some discrepancies in the terms in the sections that refer to the committee delegations, and they don't all align. So if you're happy, there is a piece of work I'd like to do just to make sure that they all align, so that we're saying the same thing for every committee, you know, and also keeping their specific remits in there as well, but so that we align those committee delegations. They're not material changes. If you're happy, I'll make those, and if you're happy to just approve and accept that they're not material, and we can go ahead and publish. Otherwise, we can, of course, bring this back, but I'll leave that for you.
So we're being asked to consider the changes to the scheme of delegation and the delegated responsibilities, and then the delegated responsibilities to committees for corporate policies. So Is there anybody who doesn't agree with those recommendations? Ellen?
I agree with the recommendations. I've taken the opportunity to review each point within, say, the committee that I'm involved in. And there are areas such as have oversight and improve the terms of reference and work with groups reporting into the Outcomes, Quality and Performance Committee, which will be the same for all the other committees. But I think we are still not clear on where we are in terms of the groups reporting into the committees, and I think that leads back to the conversation we had earlier on, Shane, about the health improvement groups. So I think there is just a piece of work that needs to be finished so that we are complete and we understand what we're doing from a committee perspective.
I mean, that might be something we talked about with the conversation with execs and non-execs as to, what is their oversight of and scrutiny of to make sure we've got the right governance in place. But
more than happy to look at that, Jeff.
Yeah, and we don't want to create a huge bureaucracy around it, but we just want to make sure people are safeguarded. So,
Rossi,
I think there's another piece of what we do around things like the system quality brief and the HCPE. I don't think they report into committee. I think they're advisory groups also. I can work it up with Sarah about how we sign those terms of reference off from a board point of view, and whether we do that internally or not. And we've also done a decision-making framework around some of the commission's policies, Sarah, so that needs time as well. So we don't have kind of separate tracks of signing off terms of reference. But I can do that outside peer review, Joe knows that.
Okay, thanks, Rosie. Any other comments? Alison?
So I support the recommendations, Chair, and with the caveat that Sarah does that piece of work to make sure there's alignment and consistency, which then may need to flow back into terms of reference committees, but that's
Okay, thanks, Alison. Anything for anyone else? Okay, so I take it we're happy to support that approach. Let me move on to the next agenda item then, which is the updates from committees. I'll start with the chairs and then perhaps go to the exec members who might want to add anything additional to the update. Ellen, do you want to start us off with outcomes, performance and quality?
Yes, I will. Okay, so this last meeting, we heard from the patient voice, which was a really good addition. It's presented by Sue Beery from Health Watch, and it created a significant discussion actually on GP access, transfer of care, and a system-first approach. So really good discussion there. But it also grounded us in our thinking in terms of what we discussed at the committee. So that was new. As we start the year 23-24, the committee will be focused on the delivery of the operational plan, really important, as well as the performance of the system and also quality of service. But the committee are also keen to get a balance on the focus for the next year and also longer-term outcome metrics. And I'd say that Sarah Weld from the Director of Public Health South Gloucestershire is really, a good member of the committee who is sort of really challenging us to sort of think sort of further out. So I think there's a good balance starting to happen. In terms of performance, 4-hour performance is good, as well as ambulance and breast cancer weight. So they've been sort of positive discussions we've had. Two areas that continue to appear to be a challenge the committee will be exploring over coming meetings are the cancer 2-week, where 56% of people are seen within 2 weeks from GP to consultant, compared to 82% nationally. So we are sort of a bit behind that. So that's something that would be good to explore. And on a similar theme, the cancer 62-day wait, where cancer treatment should begin within 62 days from GP referral. Currently, that's 43% within 62 days in BNSSG, compared to a target of 85%. Now, it's fair to say that nationally, that's not great either, but we are trailing both the region and we're also trailing the national picture at the moment. So that's an area that we will look to explore over coming meetings. And it's something that possibly Alison in her committee, we could work together on.
I think that would be great. I think access to primary care GP is the latest survey we saw at committee was that about mid-50s% of patients were still delaying going to the GP, either because they didn't have access or they were nervous of them. So we know we had had that in COVID, and we've still got it now. So I think if we're looking at the way we do, I'd be very happy for us to explore from the beginning, and not just at the institution.
That's great. Thanks, Alice.
But I think this is where, you know, across committee it's really important that we are in community, you know, we are communicating and sort of working together where necessary. And the only other two areas I think we've already touched on, which is dermatology and endoscopy, but I don't know whether Lisa wants to add to that.
So just for the board's awareness, obviously dermatology is a particular issue across both sites in terms of cancer performance, and we're doing a piece of transformation work around realigning the pathway, trying to get to a point we have a common standard, but really optimising teledermatology as well, you know, to really make it part of our programme of work. And endoscopy, we know that we currently don't have sufficient capacity, and that's part of the work that we've been doing around the community diagnostic capacity. That has been delayed till June, which means that actually implementation of that will be later. So we're also seeing what additional capacity we can get, particularly from the independent sector, to backfill that capacity. But we know that our endoscopy activity within the operational plan will not allow us to deliver the diagnostic standard that we want to be achieving for our population.
Okay, thanks, Lisa. Rosie, anything there?
I was just going to add, we also had a conversation about excess mortality rates, which we touched on earlier in the conversation. We've had some data through from region, which Joe Medhurst will pick up with our public health consultants and look at it and bring it back to committee to have a conversation about what it looks like for our population. That will probably help guide us in certain decisions about where we focus the coming year, and things changed around where we're seeing excess.
Thanks, Rosie. I mean, I think it's fair to say that performance overall is improving, and compared to perhaps where we were 12 months ago, you can significantly see a change in direction. One of the things we have discussed across committees is where do we do the deep dives to make sure that we're not duplicating effort across each of the committees and wasting time. But so there's more to be done on that. But I think that overall it's a very encouraging picture. Anything else to add from those at the quality? To Julie.
Sorry, I don't go to quality committee, but I suppose I was just looking at all the dashboards. It is very adult focused, and then when you read the minutes, I think you've got the children's dashboard, but it's easy to get lost. So here, where are we? Because when you think about at the moment some of the big ticket items in children, you know, some of the publicity we've had, it doesn't feature at this level, and people have been wrong-footed as a consequence. You know, things have come out. We've had, you know, our political members saying, hang on, I didn't know about this. Chief execs probably weren't briefed. You know, we might have felt at a lower level everybody knew, but we weren't that cited. So I suppose it's just a challenge. Do you feel in the Quality Committee actually looking at those indicators for children is as front and centre as it is around some of the adult indicators?
Lisa, did you want to comment on that?
I was going to say, it definitely forms part of performance reporting.
I can see in the minutes, yeah.
And is part of the performance report. I don't think we have done at committee a deep dive into children, if you think about the range, although, you know, in terms of those actions, but we could certainly do that at committee.
I'm not even sure it's a deep dive, Lisa.
I think it's a regularity.
I'm just thinking some of those things you're looking at, for if you looked at some of those for children, or some of the main indicators, there are some that for a very long time actually are out with.
And I would add in, we haven't got maternity data in there. Yes, either, we need to have that in as well, because I think you're right, they're two high-risk areas that we need to attend to on a routine basis.
So perhaps it's just something we can
No, I think we should take an action away for that, to actually have a look at that, Julie, and I'd be really interested in your input into that.
Yeah,
so,
no, I'd be very happy
I'll exchange an email with you as well.
So the children's data is comprehensive.
Yeah,
so we do look at everything from elective waiting lists through, and attendance in ED, and the reasons why, as well as the community data. What we're not doing is bringing it back out to the board at that level. So I think that's
I think it's a good challenge, though, isn't it? Because the performance report is vast, and there's a huge amount of information in there. Where do you shine the spotlight? And where do you make sure that where you're shining it is the most important area or the most urgent area And that's always a degree of subjectivity in that.
Yeah.
But I think that's got to be Ellen's call really as the committee chair, isn't it? With the support of the execs.
And you know, I really welcome sort of that kind of challenge so that we can actually look at what we're doing and evaluate. Paul, by the way, from Serona, who was on the quality committee, it challenges us on a regular basis in terms of children's services. So I'm happy to take that on board.
Yeah, thank you.
Any other questions for Ellen, Rossi or Lisa? No? Okay, I'll move us on then. The People Committee, unfortunately both Joe and Jay are poorly today, but we've got the minutes of the meeting. I attended the meeting. I don't think there's anything significant we need to add for the board today, but the minutes are there, so I don't know whether anybody wants to make any comment around people at this stage. Okay, I'll move us on to Finance, Estates and Digital then. Steve.
Thanks, Chair. The report's there, I'll take that as read. There are a couple of bits that we just need to click on. Firstly, the close of last year, we were trying to create savings so that we landed it in a good place. Unfortunately, we started to drift towards the end, so that's caused us a little bit more stress in the 23-24 budget setting. What we've done, however, is put a balanced budget together, but there are risks associated with that. And we are looking at savings going forward, which are around 98 million. That means the system is going to have to work hard to close that gap. It's about 3% across the system. So that does mean that we need to keep focused on closing that gap. And work at it, and we'll track it through finance as we've done in the past. One of the big areas is going to be in terms of risk workforce and agency spend. That's what caused us the difficulty last time, and given the plan, we can see that that's going to be an area that's going to stress going forward. So how we deal with workforce going forward is one of those cross pieces with the People Committee. And how we make sure that we're controlling agency spend when we can, accepting that every part of the system is challenged on workforce. So this is a really knotty issue. It's one of those big ones that we're going to have to find a way through. And those things are big issues for us to face up to. Because if we can get ahead of ourselves on that, then we start to create headroom to do investments and innovations in creative ways. And that's the sort of cycle we need to get to. I think the rest, Chair, many of the things that the Fed have been considering have now come to the board, and helpfully we've been able to sign off big capital investments going forward, which ultimately will put us in a better position. And of course we've had the SOC for the digital work, which again is about an investment going forward, which we need to work through. The detail of that still to be determined.
Okay, thanks, Steve. John, I don't understand you want that. You don't have to do that.
Just one quick one. Steve's covered the big strategic points. We did have a deep dive onto the continuing healthcare budget. And that is a budget that is starting to experience stress and pressure. And I perhaps just signal an issue that's emerging there, but there was a lot of that was about sort of high cost, high acuity individual patients, LD cohort, complex children, and I guess I brought it up because it resonates with some of the pressures that local authorities are facing within their budgets as well. And we had a good discussion then about the need to tackle that in a collective way.
So, Chair, what we decided to do is to take that outside and look at it in a more strategic way. Because I think there is a conversation that needs to be happening with Dominic and his colleagues, because they may be doing something actually that's not optimal, and that's why we're seeing costs start to spiral. So I think there's a bit of work to do strategically to unpick this and really understand a way forward.
Okay, thanks, Steve. Joe.
I was just saying, actually, interestingly, Shane and myself and the other local authority CEOs had a discussion earlier this week, and we touched on CHC as one of the areas that we need to do a deep dive in collectively. And I think it's been an area where it's been challenged for quite a number of years, to be honest, but we need to kind of work through it and crack it, don't we, in terms of something equitable so that people are focusing resources on outcomes as much as anything.
I mean, that is helpful, isn't it, to air it, to understand what's been spent where and how and by who. But
But I do think we need to get the right people in the room as we're doing that. So I think mental health needs to be in the room because that's where some of the expertise sits.
So, Ellen and Steve.
Yeah, all I was going to say, just observing this conversation, which is a really important conversation. Joe just mentioned the chief executives of the local authority getting together. Steve, you talked about getting the right people in the room. Just make sure there's not like 3 different duplicate meetings going on, and that sort of that was just my observation from that conversation there. Really important. But,
No, absolutely. And I know, as Joe said, there's been a meeting this week to discuss it. But Stephen?
Possibly an odd question. But I couldn't help noticing that on page 545, there's a table which says BNSSG System Financial Report, it's the first page, and it actually has a column marked local authorities. And I just wondered if that was indicative of an aspiration. It's blank, isn't it? It's your first financial, it's your front page of your financial report. Am I over reading into it and intention to actually have something in this report about local authorities? And
you can see I've lost my computer because of the power issues on this.
I know that's why I said
so I'm not sure exactly what page point.
Did you say 545, Stephen? 545?
Correct. It's the front cover sheet of the finance report, and it just has an interesting.
Oh yes, yeah.
And I just wondered if there was a plan there.
So I think there's got to be honest, probably at this point in time, an aspiration to try to integrate that, and there are discussions with Section 151 officers.
So, in very significant caveats, I support the idea because in my other job, chief exec, most of the conversations we have about money at the moment are to do with adults and children, and it's our biggest threat. Therefore, if this is a system look at finance, surely somehow we need that in the report.
Yeah,
we'll leave it to the 151 officers.
Yeah, and I fully support that, and I equally recognise we've got to get the balance between statutory duties and responsibilities right in that as
but it would give other members a better understanding, I think, of the whole system picture.
And if I could, I think Steve would be really helpful to reinforce that with the 151 officers, to say that, we're doing this because we want to understand how best to run as a system. Because I think it's also probably quite threatening, is not the right word, but it's challenging to think as a system. So we don't want that information for any other reason than that we can all understand what best to do. And I think we're all on a bit of a cultural journey on that one.
We can have the conversation. I can well understand why they're reticent.
Oh, totally.
Except to say all that information is already published. So it's in all of our accounts, our budget papers. We've been fully scrutinised on it.
Yeah, so this is probably one for you to take away with the chief execs, really. Shane,
Yeah, no,
I think to have that conversation about system finance and the conversation with the 151 officers. But, what comes back to the board, I think would be helpful to bring that into the finance committee and into our papers here. Okay. Any other questions on finance, digital and estates? Because we had a fair number of papers on those today, but is there any other comments people want to make? Okay, can I move us on to primary care then? Alison.
Thank you, Chair. 3 points from me, and then I'll do a seamless pass today. But at the last committee, again, we did head inputs and partners, which we always had. It was the last meeting before active delegation happened, so the transaction has happened, and the amount of work that Dave and his colleagues have put in is enormous. I think what we don't want to lose sight of is what's the benefits, what's the outcome of the benefits. And we've already, one of the comments I made before parenting was around dental services and actually what can we do. So there's something about the opportunities that present themselves, and in fact we started to see some fertilisation between the local dental community and local pharmacy community and primary medical services, which actually wouldn't have been a big thing if they hadn't been to. But Dave has a separate briefing paper on delegation, which is an action from the last board. There are some revised terms of reference here where they're highlighted in yellow for board approval to add in advanced autonomy and density. So I would like the board supporting that with the caveats that I would want small percentage are referred back to the originator, but most are dealt with advice or advice and treatment. And actually, what committee was really interested in was the scalability of that, because, and Rich Brown, the local pharmacy representative, I think we're lucky to have him in our patch with his drive and his energy to do this. So there's something here about helping all the other bits of the system. Rich told us about pilots underway with ED and UHBW, which the RIS lab would be interesting. And as I say, we supported that, and we really wanted to test on how quick can you go, how far can you go, how can you scale those up. So I think worth mentioning to all, because it's those sorts of things that they come into fruition in this policy. So it was a good thing to know about, and we've got good assurance. And I think when you look at the pharmacy contribution, they are very keen to contribute more. And I think there's something that has that help. So those are the two things, the delegation and the community pharmacy scheme. So if you're looking at take representatives, all right. And then I'll hand over to Charles.
Thanks, Alison. And there is a briefing paper on delegation in the pack, because I did want to make sure that this board is formally briefed on the process that we've been through and the due diligence that we've been through in terms of our assurance prior to delegation on the 1st of April, which has now happened. It's a huge amount of work from all ICB teams in getting to that process, including some around the table here, so thank you directly for that. It is a real opportunity for us to better integrate pharmacy, optometry and dentistry services back into our health and care system. Alison's already alluded to some of the opportunities we've had specifically with pharmacy. So it's a real opportunity for us, and we'll continue to brief board on that progress. Just in terms of the formality, the delegation checklist was approved through Primary Care Committee and the Finance Committee through January and February, and then on the 23rd of March, Shane formally signed the delegation agreement. It was a lofty moment, and aligned with that was a memorandum of understanding to clarify our working arrangements with NHS England and the commissioning hub, and how we support and how we get our support in commissioning those services from NHSE. In the paper, this is a period of transition, I'd describe it as, and there continue to be some areas that we work with NHS England on in terms of our processes, and they will be set out in a transition plan, and that was part of our that was a caveat to our signing the delegation agreement, and those areas include clarifying the governance arrangements around regional versus local decision making, complaints management and the clinical leadership architecture. But we have really strong conversations and continued dialogue with NHS England in confirming that transition plan. Alison has noted the changes to the terms of reference and the SORD. We are also finessing and changing the terms of reference for what's called the Primary Care Operational Group, the group that I chair, where we collectively come together to work through decisions relating to commissioning of those services, and pharmacy, optometry and dentistry will be joining that group from April. We have really good engagement with the LDs, with the Dentistry Committee, Pharmacy Committee and Optometry Committee already. We've engaged them in primary care for the last 6 months, and it's put us in a strong position to embed those services in our system moving forward. We didn't mention the provider houses as well, yeah.
We also, as providers, have started to come together regularly over the past 45 months, and we are talking, there's an emerging concept of primary care, which is just a confederation of together the 4 primary care professions, the similar way we have done with general practice, So we do very much as general practice, we're offering in support, lessons learned, how we can be coming together, trying to actually
Chair, the paper's there to formally note delegation to the board, and also to seek ongoing delegation of assurance through the Primary Care Committee.
Okay, thanks, Dave. Any questions to Dave or Alison? No? Okay, thanks very much, and thanks for the update. Audit and risk, John. Anything you want to add from the Audit Committee?
Thanks, Chair. Just a couple of points. Briefly, 2 sets of minutes here for information. The February set is part of the planned cycle. The second meeting was unplanned. The meeting that we had in March was unplanned as we had a delay on the part of the external auditors in providing us with the year-end plan. So we needed to put them under a little bit of pressure, and it's a bit more complex as it closes off the last 3 years of the CCG and the 9 months of the ICB. And I don't expect that we'll need that in future. The only thing I wanted to flag is the fact that I think everybody should have had an invitation to a couple of risk workshops that are happening in late April, early May, and I would just urge you all to try and put yourselves onto one or the other and to contribute. Like, risk has clearly been a thing this morning and today, and just it builds on the work that we did in January. So it's just I think it's a good opportunity to refine that. So that's it from me.
Okay, thanks, John. Any questions or observations for John? Okay, thanks very much. We're on the final stretch. BNSSG Integrated Care Partnership update. We had a lot of discussion at the last board meeting strategy, and Colin gave us an update. Since then, I mean, that is the primary focus of the Integrated Care Partnership Board at the moment. It is well attended. There's a lot of energy behind it. There's a huge amount of consultation going on with the strategy. I don't know if anyone in the room was part of the prioritisation seminar last week where David Wynick talked about, but yeah, so actually that was quite useful. David really gave us a sense of, the strategy might be the whole elephant, but what are the bits that they're going to ask us as an ICB to focus our attention on? So that is all being refined as it goes forward. We're expecting the strategy to be signed off by the end of June by the ICP. And then obviously that comes to us to make some sense of how we're going to deliver that as an ICB. Shane, I don't know, is there anything else you'd want to add from the Integrated Care Partnership Board?
No, apart from there was real energy at the last meeting and a desire to be part of something, really strong desire, which is great both from the volunteering community and the statutory sector. So it was actually a really positive meeting, and it was great to see people really engaged.
And we have made some money for the voluntary sector to be engaged in the Integrated Care Partnership and beyond, as I mentioned this morning. But there is a really good voluntary sector engagement. That then turns me to the question here, I was going to just table with you, was today was the last input from our locality. Oh, we've got one more, have we? May. Oh, okay, my fault, sorry. We've got one more in Woodsbury in May. After that, it was my intention to bring in the patient voice, so we start this session with a patient who, as much as we can coordinate it, has touched most of our services, and they tell the story of their journey. Now, I do understand that can take a big chunk of the board away if it's not handled in the right way, but just open to views on it, really. Is there something else you would like to see in there? Because I don't really want to do another round of inputs from the locality partnerships just yet. Open to suggestions of what else it might be, but I just think it might set the tone right for us. Dominic? A site visit. Now, so let me take it away and give it some thought, but I do want to make sure that we start this meeting setting the scene in the right way. And I think locality partnerships have done that, and I think they will feel engaged with us, but the patient voice, we need to think about where we land that in our conversation as well. Okay, that's fine. I don't think there was anything else from me on the next, unless there's any questions for me. On the final bit around questions from members of the public, we have had one written question from Ron Mendel, who's a regular contributor to us here and to the ICB. We will write back to Ron. I don't think, Sarah, there's anything we particularly need to cover here now, is there? And then just open to the room, really, if there's any questions from members of the public in attendance. No? Oh. Yeah, I mean,
The questions were about the scheme of reservation and delegation and related to the primary care delegations, so that they're quite sort of technical and detailed.
With the new
we'll
services.
go back in the new services,
Yeah.
so we'll come back with a written response, and that written response will be sent to him, and we'll also place it alongside the minutes, so it will be in the public domain.
Okay, so that moves me to any other business. So is anything anyone else wants to raise that we haven't? Alison?
Just a tiny process one. Can we minute that we've approved the terms of reference? I think for the primary care committee.
Yeah, sorry, my fault if that wasn't clear. So, yeah, fine. Well, unless there's anyone objecting, I don't think there is. Julie?
I wasn't going to object. Sorry, my hand went down. It's an observation, really, and a request, perhaps, so we give it some further thought. Just reflecting on the meeting, thinking about almost, just was noting, the digital transformation piece talked about culture change. The locality talked about the importance of culture. The Western General said this is not just about whatever, it's culture. The rugby club, the care traffic control, and then when we last talked about D2A, we had a massive piece about culture change. And each of those I know, or not all of them, but some of them I've been involved in, I know are looking at programmes of culture transformation change, which are big money attached. And just reflecting, actually there's probably 80% of it that's core across all of them. And then there'll only be, I made up 80%, but there'll be 20% that might be specific. And I just wonder whether as a system, we just need to think about a piece of work, about how we're all going to work differently, the culture that we want to see. Otherwise, there's a danger we're going to spend a lot of money duplicating. So it's just a reflection and for discussion at some other point.
So I mean, perhaps I'll pass on to you, Shane, but give you a chance to think about what you're going to say. We did. I think we did sort of start that, didn't we, with the first couple of meetings we had. So prior to July, with the shadow board, those first 2 or 3 meetings, the seminars that we had, where we talked about the way of working, the type of board we want to be, the type of behaviours we want to demonstrate within this room. But you are right, Julie, that extends beyond this room, doesn't it? And so how do we land that in some of our change programmes? Shane, I don't know whether there's anything you'd add to that. It's a good point.
I don't disagree with you. I'm struggling to think, what does that mean in practice? So if you take the Europe stuff that we looked at, D2A, I mean, so much of that is about culture. I don't know, I'd like to think, because absolutely every change we enter into, every paper we bring here, the success will be because we have not just done systems and processes and people, we've done culture. So it's a good point. I don't know where that good point goes.
No, I don't either. So I just wanted to share it so we could at least...
And if you've got any particular ideas on
give it some
what you think that might look like, that would be really helpful. Any other comments on that, or any other business? Sorry, Deb.
There's an email in your inbox.
We've heard that before.
It might work.
Yeah, it might look like spam. I went through it with Stephen and he went, this really does look like spam. It is not a phishing exercise. It's no/reply.facultyai. That is your personal invite to the traffic control. I do need to get them to change the invites and how it looks.
Because it does look like
because
the black
it does
background
look
and
like
stuff.
spam, yes.
Don't
I've got a
touch it.
slightly different one, so I've texted them and told them they need to sort that out because a lot of people will be throwing it into their spam box. But yes, if you were able to have a look at that, that would be amazing and we can achieve our objective of getting it connected.
Okay, lovely. Thanks, Deb. Anything for anyone else? Okay, thanks very much. Date to the next meeting and location, Sarah?
May the 4th, and we will be in Portishead in Somerset Hall.
So look forward to seeing you all then. Thank you for your time today. I think we've generated some really positive discussion, and the days move quite quickly when you think how much we've had. It's just gone 3 o'clock, and I know it's been a long day, but thank you for your contribution and really appreciate everybody being here. Have a good Easter. Let's hope you're not working too hard. Just to read the selection.